Thank you. And again, we're going to have 30 more minutes with Christa to talk about the nuts and bolts of our collaborative. So we're going to transition now with that as the focus.
Well, it's not quite 30 minutes, Elliot, but I'm going to do my best. So I'm going to introduce the Improving Diagnosis and Treatment of Obstetric Sepsis Collaborative that we're going to be hosting here in California. Next slide. So just a little bit about CMQCC and what we've done with collaboratives in the past. You may or may not be familiar, depending on about how long you've been in the state or how long you've been following CMQCC if you're not within our state. We've done various collaboratives on preeclampsia, hemorrhage, reducing primary cesareans, mother-baby substance exposure, and those collaboratives are all what we call complete or in a sustainability phase. For birth equity, we had a pilot collaborative that kicked off several years ago, and that group actually is still ongoing and informing some of our current work that we do on equity in California. Back in May, we kicked off our learning initiative for supporting vaginal birth with an equity lens, and that collaborative is going to continue through multiple hospitals for the next 3.5 years. We also are currently doing a collaborative on low-dose aspirin to prevent preeclampsia. We just kicked off a pilot this month on a community birth partnership initiative that connects hospitals with their community birth systems, and where you all are today at our maternal sepsis collaborative. Next slide. So this has traditionally been the mentor model that CMQCC uses to run collaboratives, where there's a mentor physician and a mentor nurse that kind of oversee all of your hospital teams. So groups of usually 6 to 8 hospital teams have an assigned mentor physician and mentor nurse that kind of guides you through all of the implementation tools and practices that are developed for the specific collaborative. Each one of those meetings is overseen by a CMQCC clinical lead, or in some cases, Elliot himself, to just kind of spread that information across groups. We also guide the mentors in sharing that information across groups. And what's really exciting about this collaborative and some of the other collaboratives that we have going on is that instead of just having kind of patient advisors, we have patients that are going to be participating as mentors. So you can go ahead and click, Rebecca. So we have mentor patients that are actually going to be very involved with their own hospital teams so that they can have that same relationship that the mentor physician and the mentor nurse have, as opposed to just kind of diluting that knowledge across all of the groups in totality. So this is a really exciting space for us to be in, and we're happy to kind of redesign the collaborative model. Next slide. So we always, when we're doing all of these collaboratives, we like to try to get all the hospital teams to get all the building blocks in place sooner rather than later, so that they have a nice effective team, so that as all of the implementation practices and tools and resources come out, that there's people of all different backgrounds and expertises that are going to be able to assist you in implementing this in your specific hospital. We want you to really engage your bedside staff, because they're integral, right? They're going to be the ones who have to day-to-day are the ones that are going to be applying this to the patient. So making sure that they're part of the project and that their feedback is important really helps expand their QI knowledge and helps them want to be part of the solution, as opposed to like, oh, here's another QI project, another thing that we're going to have to redesign or do, and it feels like a burden because no one actually takes feedback from the staff, the bedside staff. You want to think about how you're communicating the status of the project, when you're rolling it out, what pieces you're rolling it out, what your PDSAs are, what you're looking to hear back. You want to figure out who you're going to disseminate specific information to, whether administration is involved in some of this information, whether it's just bedside staff, whether it's a combination of both, depending on what the topic is, how you're going to communicate that, whether it's QI boards or email blasts or read-in signs or email, whatever it is. You want to design that ahead of time, like how are you going to communicate these various pieces to the various people that you want to communicate the status of this project to, and what the timeline is for that. Any scheduled meetings that you have, and usually when we're starting something new, we recommend monthly, or if there's some other schedule that works best for your hospital, that you develop it and that you stick to it, make an agenda and prepare for those scheduled meetings so that everybody knows what you're going to be talking about, discussing, or refining when you get there. Next slide. So standard team members that we've had in the past for collaboratives are physician leaders, OBs, MFMs, midwifery leaders, if you have midwives within your facility, nurse leaders, and that can span directors, managers, CNS educators. Depending on where your OR is, there might be different people interacting that are not necessarily quote unquote OB, but you want to think about what their role might be. informal leaders, we all have those nurses on the unit or physicians on the unit that maybe you're not the OB chair or the charge nurses, but they do have a lot of pull and weight. People really like them. They're good at engaging with people. You want to try to pull them into projects like this to help, with the spread. Our data colleagues, we've learned, even I've been with CMQCC almost 7 years now, and we've really leaned into data colleagues and how much that they know about some of this reporting, some of what we do with the adult inpatient world that we can kind of pull into the OB world to help us understand what all of our metrics are and to really be able to measure our progress. So this is our quality staff, our patient safety risk management staff, our HIM departments, and our data analysts. Next slide. So supportive team members. So this is a slide that we're kind of updating and transitioning, right? Because we used to look at patient reps and community representatives as kind of a supportive team member that we would kind of, as Kendra alluded to earlier, kind of develop something, run it by our patient and community reps and go, hey, is this okay? With this project, we're kind of getting those partners in early on so that we have some feedback early on. So as these things are being developed, they're being developed with these voices right from the get-go. So we encourage hospitals to try to mimic that model. Think about your administrative leaders, because they're the ones that say yes or no and can provide any kind of fundings or resource allocations within your facility. Board of directors, your community leaders, your marketing departments, and of course your state collaborative, which if you're from California is us, CMQCC. Next slide. So why a collaborative? Next slide. So the reason for the problem here is that obstetric sepsis is the #2 cause of maternal mortality. Obstetric sepsis is the #3 cause of severe maternal morbidity. And then we all know that the Joint Commission and CMS are introducing several SMM quality measures this year that involve sepsis. The implementation of the sepsis bundle is one of 3 safety bundles, in addition to hemorrhage and hypertension, that CMS is requiring for that birthing friendly designation, which is new. Next slide. The collaborative is a multi-stakeholder, which I think we've already said, that's multi-hospital effort that improves the prevention, diagnosis, and treatment of sepsis in California. And in this project, we are working with Michigan as well. Activities are going to assist hospitals across the states of California, Michigan to improve outcomes through the implementation of safety bundles that came out from AIM, or the Alliance for Innovation on Maternal Health, and our sepsis toolkit, which we'll be going through a revision. So Elliot had spoken about all of the data that we received. And so there are going to be some updates to that sepsis toolkit that should be coming out in the earlier part of 2024. Next slide. So why are we doing this collaborative now, right? The sepsis toolkit came out, I think, the first year that I was with CMQCC, so it's been a minute, and we didn't do an associated collaborative at that time because we didn't really have any grant funding for that. So we are very excited that we received this NIH grant to further our work in obstetric sepsis, really fine-tune that toolkit and that screening process and the assessment process, and upgrade the toolkit. Also, in the last few months, ACOG and AIM released that new safety bundle, sepsis and obstetric care, and that has a lot of great resources along with that change package. So this collaborative starts today, right, with this kickoff on November 7th, and it's going to run through November of 2024 with the closing. Next slide. So the collaborative structure that we'll be utilizing throughout this year is completely virtual, which is a little bit different than we've done collaboratives in the past. This is the kickoff webinar. We will be doing mentor training for all of those hospital mentors, so the nurse and physician teams, as well as the patient mentors. That'll be occurring during this month. Every quarter, there will be an educational webinar. So as the beginning of this webinar was really all of that background information, kind of treatment information, evaluation information. That's going to happen once per quarter. And then that will be followed up by 2 quarterly small group meetings where those hospital and patient mentors meet with their hospitals and share with their peers. The first meeting of each quarter is going to really focus on clinical protocols, with the second meeting of the quarter really focusing on patient considerations and how those two mesh, and what the best way is to roll out those implementation projects. Other experts will appear throughout the collaborative, some in patient safety, implementation, quality improvement, data analytics, just to help the hospital teams with any kind of sticking points or barriers that we experience in those small group meetings. Additionally, mentors will be meeting. So the mentors from all of the groups will be meeting together quarterly to, again, share all that learning between groups so that you're not just learning from your 6 to 8 hospital teams, but you have the benefit of learning from all of the hospitals that are participating in the collaborative across California. And that closing webinar happening in November of 2024. Next slide. So resources that we're going to be utilizing predominantly will be that revised sepsis toolkit from CMQCC and the AIM bundle. Next slide. In addition to those, our hospitals come up with some great things. Some of the things that we love to talk about the most at CMQCC are things that are complete, inventions of our hospitals throughout collaboratives. And so we utilize this website called Share that is accessed through CMQCC accounts to kind of share what all of our hospitals have come up with during the collaborative so that we can steal shamelessly from each other and not have to reinvent the wheel. Sometimes, you can take somebody else's example of, let's say, an order set and tweak it a little bit for something that works within your facility and not have to start from scratch, which really minimizes the burden of an implementation project such as this. So all of the hospitals in California that are participating in the collaborative actively will be in a special sepsis share group where they can go ahead and upload and download all of these specific tools that we utilize throughout the next year. Next slide. So the benefits of hospital participation in a collaborative such as this is that you actually get to extend your QI capacity by interacting with other hospitals and us. And the way we do that is that we're providing training materials, we're providing the educational webinars, which you'll be able to share the recordings and slides with your groups back in your facilities if they were not able to attend this live webinar. The development and implementation of all of our standard approaches to care, which again, sometimes work directly in your facility and sometimes just require a little bit of tweaking to be the ideal model for your hospital. You'll have mentor support for the implementation of bundle elements. And sometimes it's just, basically another person saying, well, have you tried this approach or that approach? Sometimes we kind of get stuck in our 4 walls of the way we've always done things. And it's nice to kind of have that outside of perspective. You'll have assistance from those quality improvement experts that I mentioned earlier, and you'll have all these opportunities to network with hospital teams across the state that are participating in the project. So sometimes we get great support from hospitals that are like us, right? Either same size or same geographical region. And sometimes we get great support from a hospital that's not like us because they've kind of looked at it from a different perspective. So that's the real beauty of the collaborative, is that you've kind of got all of these different approaches that you can learn from and draw from. Next slide. MDC tools. Next slide. So within the MDC, which is the Maternal Data Center, so if you're in California, you probably are familiar with this. This is where we collate all that data, right? Your discharge data and your birth certificate data, and that's where you get to look at all the numbers. But over the years, we've also developed some of these kind of interactive structure measure checklists so that you can follow where you are at with the implementation project. So the one that we've developed for sepsis has got 10 structure measures total, and you'll be able to go through in the MDC and mark when you completed something, what's not in place. You can generate a PDF that will show you your progress. You can generate a % complete trend line that will show you your progress. And these things are nice to embed when we have department meetings or we want to meet with administration to kind of show them where we are and again, elicit any kind of support we need to complete the project or the pieces that we're missing. So I know, as a nurse, I know that we love lists and checklists. It just kind of keeps us really organized. In addition, it will help us on our side, on the collaborative side, be able to see where our hospitals are with the completion and see if there's a common area that there's a sticking point that we need to address or we could offer more support from. So that's super exciting on our side. Next slide. Just to kind of glaze over this, there's multiple help guides and within the MDC. If you don't know how to utilize your SMM measure analysis, there's been a whole bunch of tools that have been created around SMM in the last year to year and a half, and lots of great guides associated with this. So as you want to track any of your SMM and you want to specifically focus on sepsis, you're able to utilize measurable analysis tools within MDC. Next slide. And then further than just bucketing it into the different types of SMM, you could actually break down into underlying cause. So this is something we'll talk about a little bit more throughout the collaborative, but I just wanted to introduce it in case it's something brand new to you that you can go ahead and just go into the support section of the MDC and download all of these user guides. Next slide. So what we've learned over all of our collaboratives, or all the ones at least that I've participated in, are some really specific quality improvement pearls that sometimes feel like maybe no-brainers, but when we don't pay attention to them and we don't give them the attention that they need, we don't kind of get the same kind of power and camaraderie associated with QI projects, because as we know, they're never ending, right? Next slide. So all improvement is multidisciplinary. And again, as I mentioned, super exciting that we're really engaging patients from the beginning of this. So even more multidisciplinary when we're engaging with people with lived experience. We want to cast a wide net to get the right people to the table, including our patients and community partners. Don't forget those informal leaders. They can really help produce and kind of cheerlead to lead to favorable results. And engagement of hospital level QI personnel has really improved effectiveness because they're able to kind of track all of the measures like CMS and Joint Commission, et cetera. Next slide. Things that we've learned is that those robust teams are most effective. Easy wins matter, even if it's something as simple as like we rolled out this education, or we we got this order set, or we just created our QI board that's showing that we're going to be working on sepsis in the next year. All those wins should be celebrated because it's all part of the project. Goals and timelines are super useful. We know that things have to be altered depending on what else is going in the hospital, but kind of laying out a roadmap for yourself and when you hope to achieve things is really helpful for keeping your eye on the prize. Remember, it takes time and a lot of persistence to get these systems running smoothly. That's why PDSA cycles are so important, so that we don't kind of go all in on something for the entire unit and then find out that it's not going to work for us. And that all these projects have to have champions. It's kind of been commonplace in the past that we've got like 1 or 2 people that are working on change projects, and it takes forever, or it never kind of takes root because there's not a buy-in from the whole unit. So those champions that can kind of live and breathe this on a day-to-day basis are really helpful for keeping the project alive. So want you to really think about all the disciplines and departments that are needed to help achieve success in this project. Obstetrics tends to be kind of a silo. We're a little bit out of the adult inpatient box sometimes, and we kind of just rely on our own players. So really expanding outside of that to kind of lessen the burden. I already heard, people ask questions about pharmacy. So great, bring those pharmacists in early so that you don't develop a whole protocol that pharmacy says, we can't utilize here because of whatever reason. Our anesthesia partners, what do we need for IT and our EHRs, our lab personnel, really focusing on emergency department and what we want their response to be with obstetric patients or postpartum patients, any kind of support personnel, our outpatient clinics, our patients, or anybody else that might be unique to your specific setting. Next slide. Don't forget to celebrate. And, the hospitals have come up with all really creative ways to celebrate little wins in their hospital, or even just like quarterly marks, just kind of check-ins of where we're at, what we've accomplished and where we have to go. Different things work with different hospital cultures. So think about what you're already doing or already implementing, or something that's very popular within your hospital, and lean into that. Next slide. Questions. I did pretty good. Thank God I grew up in Jersey. 1:30 on the dot.
You get the prize. Thank you so much, Christa. It's always been incredible working with you over the years. So anybody have any questions, or did Christa leave you speechless? We'll be going over these in greater detail as the collaborative unfolds over the next couple of months. We wanted to give you a flavor just as we're starting, but if folks want to unmute, you can ask them verbally, or you can ask Q&A. We don't care at this point.
I don't think they can unmute on a webinar, actually, Elliot. So Q&A is where it's at. While we're waiting, is anything going in the Q&A?
Nothing's in the Q&A so far. If you want to follow up, Dr. Main, with any announcements or reminders.
So I just caught one question. How would this be rolled out to hospitals outside of California? Well, Michigan is doing their own collaborative. Other hospitals could decide, other states could decide their PQCs to pick up. We meet with other PQCs all over the country all the time to kind of talk about what our model is here in California, and they can do their own version. Hospitals individually, which we have all the time, hospitals will individually go ahead and pick up the AIM bundle and the CMQCC toolkit. These webinars are open to everyone. This is open because you're here, right? Open outside of the state of California so that you can kind of do a self-guided path. And we do answer a lot of questions. So if you get stuck anywhere, go ahead and let us know. I do want to talk about some upcoming webinars that we have throughout CMQCC and OB. The next one being on November 15th about perinatal equity. This topic is specifically patient experience, baseline assessments, and respectful care. You can go ahead and scan that QR code in order to register for that. You can also find that registration link on the CMQCC website. Next slide. Also the hospital action guide. So this is really targeting a bunch of different tools to be utilized in hospitals to really address different equity. It's only available, unfortunately, for those of us outside of California. It's only available to California hospitals, but it really starts from the beginning with a nice little explanation of exactly how to use the guide. And you can go step by step through it. We hold monthly office hours where we can answer any questions that you might have about implementing things in the hospital action guide, or if you can't find something, or if you want to know where to look for it a little bit better, we're there to support you on top of being, this kind of self-guided program.
There's several questions in the chat regarding the next training for the mentor training, the date of the next meeting.
So mentor trainings are November 15th and November 17th. I'll certainly go ahead and tap all of the mentors that haven't already registered for one, but I'm pretty sure most of the mentors are registered for one or the other of those. The next meeting is going to be in December, and the one after that's going to be in January, and everybody on your team should have received calendar invites already. If you didn't receive one, it's probably because you didn't turn in your commitment form. So I didn't have everybody's emails to email them directly, so they only went to your leads, and they were supposed to disseminate it. But Ruhi, thank goodness, has just come to rescue me about a week and a half, 2 weeks ago now, I guess. So we'll be going through who might be missing from those lists and resend out those invites to the best of our ability. But if you don't have that hospital commitment form in yet, if you could get those in ASAP, that will help us really get out all these invites, resources, and everything so that you don't miss anything.
So December and January will be the small mentor group meetings,
Correct.
i.e. the hospitals, and they will have topics to discuss. There's a question about the first step. We should be sending something out in the next week or 10 days that would give an order of topics for the next months. So stay tuned for that. But again, you should have all those, your hospitals should know when your meetings are scheduled in December and January.
And if you're not sure, just send us an email and I'll make sure you know what group you're in.
Victoria, I think you probably are going to need to write it. You have your hand up.
Okay, great. Looks like we just have a couple more questions in the chat. Looks like a technical question for you, Dr. Main. Some patients with infection and fever, running WBC, HR, and R normal already show end organ dysfunction, like decreased urine output, antibiotics, and starting for infection. How would these patients be handled in CMQCC protocol? Get confirmatory tests of step 2 or CBC to check if more recent WBC would be second SIRF.
We'd want to look at the exact numbers because, again, we're not following SIRS, we're following pregnancy-adjusted SIRS. But in any case, if you have an infection and you have one of the other abnormal signs, key signs and symptoms, such as perhaps reduced urine output, and you're suspecting infection and she's not bleeding as a cause of reduced urine output, I would go ahead and order the end organ injury panel and make certain, give her fluids, of course, fluids, antibiotics, and the end organ injury panel. In terms of the CMC toolkit, we're planning one major update in 2024. We've had a series of groups working on the patient-reported issues and the screening tools that we discussed today. Those are the major emphasis for the changes in the toolkit. The rest of the toolkit is in pretty good shape.
Excellent. Thank you
Well-
all so much for joining us.
And thank you, Christa, for keeping this reasonable on time. Thanks.
Thank you. Take care.
I
Bye-bye.
look forward to working with everyone over the next the next year. Take care.